time, I'll start with the session. There is a slight change in the speakers. Unfortunately, Dr. Rajesh Sinha sir could not join with us. So that topic will be just briefly covered by myself. I'm Dr. Arjun, a cornea consultant, Comtrest. So my first topic is a clinical topographic overview. It's just a topography overview course. And the next one is a corneal cost linking, after which we'll have the minimally invasive approach by Dr. Uddaraja sir and keratoplasty and keratectasia, the final frontier by Dr. Shirish sir.
Good afternoon, Arjun. Arjun is going to give an introduction on topographic overview and ectasia, how to manage and how to diagnose, make a diagnosis based on the topographic findings. Over to you, Dr. Arjun.
Thank you, sir. So this is my humble attempt to give you an overview of topography within the next 8 to 10 minutes. So corneal ectasias can, as you know, definition is non-inflammatory progressive, the hallmark being a steepening and thinning of the cornea. There may be the types, it may be a primary or a secondary, the primary being the keratoconus or PMD, the secondary being the post-LASIK versions. And it may be, you can define as central or the peripheral ones, the peripheral ones being the PMD, the terians and the PMD like KC. So ectasia mostly is bilateral but is mostly asymmetrical. And topography has been the gold standard in evaluating any ectasia and also understanding the progression. It has even the topography has evolved from the Placido's disc all the way to the present generation ASOCT devices. So the basic principle remains the two, the reflection based and the Scheimpflug based or elevation based, which includes the Scheimpflug or the ASOCT based devices. So in the reflection based devices, you have a calibrated Placido disc which is projected onto the cornea. The reflected image is then digitized and calibrated based on the size of the image and the size of the disc which is projected. You get the keratometric power for the individual location and the maps are created. In slit scan technology, you project a slit onto the cornea, and after the slit is reflected back, individual points are calculated by what is known as triangulation. That is solving a triangle. If you know the distance between the camera and the eye and the reflected light angle, you will get the point-to-point values. So going on to the Scheimpflug principle, if the image plane and the lens plane is parallel, then the the object plane and the lens plane is parallel, the image will be quite clear. But in our case of cornea, it is not parallel, it's a curved thing, curved surface, so it will cause distortions. So in such a case, by distorting the plane between the object and the lens, you can get a much clearer image. This is something which we intuitively do when we take a selfie, that we either tilt our head or the phone to get a better image. That is the simple principle of Scheimpflug. So the prototype device in this case is Pentacam, which takes multiple images, and from these images it finds the shape of the cornea. In other words, here the elevation is determined first, then subsequently the power is calculated. In other devices, the power was calculated, from the power they determine the shape. So any of the topographic maps will have the chord maps, which includes the anterior elevation, posterior elevation, the corneal thickness and the keratometric or the power maps. So going on to it, first understand your parameters, the color conventions. The cooler colors will show lower areas, flatter areas, or thicker areas in the respective maps, and the warmer colors will show higher, steeper and thinner areas. So on a cursory note, these two eyes may look similar, these two maps may look different, but as the same eye. Only thing which is changed is the scale. The first one is an absolute scale, where every time the map is, the keratometric power has the same color convention, but the next is the relative one. In the relative one, the machine determines the lowest power of the eye, highest power of the eye, and then redesigns the map. So absolute, it is easier to compare between visits, compare between eyes, when the color coding is always the same. Again, this is another thing you have to see, the gradient of change. This is the same eye, but the gradient changes, the steps have increased, either 0.5, 1 or 2. As you can see, when it becomes 2 or when it's more lax, the details and the patterns start disappearing. In other words, even an abnormal eye will start looking normal. One more thing you can change in present generation devices is the diameter. This becomes important when you're dealing with a peripheral ectasia, because in such cases you require more than 8 millimeter, 12 millimeter maps to identify the peripheral thinning as well as the peripheral keratometric powers. So this is the overview you have to see. And now you can go for interpretation. But before you interpret any patterns or parameters, you should understand your reference. The reference commonly used was the best fit sphere. The newer devices have the other references like best fit toric ellipsoid or best fit ellipsoid, toric ellipsoid fixed, etc. So understand the reference before you interpret the parameters. So in the keratometric map, one more thing you have to see is the strategy used. Just a brief overview, the two strategies you can use is the sagittal or the axial map or the instantaneous or the tangential map. In an eye like this, there are subtle areas of elevations, and when you try to take a map out of it, your axial map will only generalize the whole map, but it will not show you the subtle variations. So you have to find out the tangential map in which the subtle variations are represented by the different radii of curvature. In other words, to get a general overview, you can use an axial map. To find out surface variations, you can use a tangential map. Finally, going into the patterns, you have the commonest 10 patterns in the holiday. In the maps, it will look like this. You have the circle, the oval, the inferior and superior steepening, the bow ties, which may be symmetric, asymmetric, or with skewing or without skewing, and last is the irregular pattern. There are some specific patterns like this, the butterfly, crab claw, or the vertical D. This commonly occurs when the ectasia starts moving away from the center, which produces a phenomenon known as the loop cylinder. As the ectasia further moves away, the loop starts coming into picture, and the butterfly starts to look like a vertical D. So this is more seen in peripheral ectasias. So again, you have to see the ocular surface. Sometimes the dryness, even scar and previous surgeries will induce a topographer, and you will get an irregular pattern. One more aspect is in any topographer, the astigmatism is represented by the bow tie or two ellipses. If it's a regular astigmatism, both the ellipses will be in the same radial axis. But if it is irregular, one of the ellipses will start deviating away from it. This is known as a skewing. And the amount of deviation will give you the idea about whether it's significant or not significant. This month, we have lost many veterans in ophthalmology, and one more person we lost. And you can't say topography without saying the word Rabinovitz. So this month, he passed away. So we have all these criteria which I said are part of the Rabinovitz criteria. So going on to the map patterns, one of the patterns you have to see for is an asymmetric bow tie with skewing of the radial axis, because this can happen only in 0.05% of normal population. If you see this, you are more likely dealing with the ectatic person. Going on to the parameters, I'll try to cover both the devices at one go. I apologize for doing this. So keratometric map, one thing you have to see is the Kmax. The Kmax, if it's less than 47.2, it is normal. More than 48.7 is mostly abnormal. And next you can see is the posterior best fit sphere. That is the power of the posterior best fit sphere. Less than 52 is considered normal. More than 55 is considered abnormal. You can also take the ratio between the anterior and posterior. So this is one of the Escarpate's criteria, where the value less than 1.2 is normal, more than 1.27 is considered abnormal. And keratoconus mostly is an inferior steepening. So if there is a difference between the inferior and superior powers more than 1.5 diopters, it is considered significant. And when it becomes superior inferior steepening, it has to be more than 2.5 to be considered significant. So going on to the elevation maps, before you see the maps, you can see that based on the best fit sphere, some part will be above it, which will be represented by the warmer colors, and some part will be below it, which will be represented by the cooler colors. So if there is only a uniform power with a central elevation, you will get an island, and if there is an astigmatism, you will get an hourglass kind of pattern. Again, you have to see for the reference use. This is the same eye. One is the best fit sphere, the other is best fit toric ellipsoid. The best fit toric ellipsoid helps you identify the cone location. It's more sensitive in finding out the subtle changes in the eye. So again, the criteria, anterior elevation more than 40 or a posterior elevation more than 50 is considered abnormal. If you see this caricature here, some areas are above the best fit sphere, some areas are below the best fit sphere. So the difference between the highest point above and the lowest point below should not be more than 0.04 mm. If it's more than 0.05 mm, it is considered abnormal. Again, you have to also see for the reference used before you use the values. In case of BFS, a value of more than 8 microns or 18 microns for posterior, and in case of toric ellipsoid, 12 and 15 respectively are considered as abnormal, depending on the whether it's myopic or hypermetropic. So for the pachymetry map helps you identify the central area, which is the most thinnest, where the cone is likely to locate. So in this map also, you have to see for the values. Anything more than 500 is usually normal, less than 470 is abnormal. Another thing you have to see is the change within the map. That is, the 7 millimeter zone is compared to the thinnest location. There should not be a difference of 100 between these two locations. And another thing is, mostly our cornea, the central area is the thinnest. If there is a difference between the thinnest location and the center by 30 microns, it is considered abnormal. One more thing you can see for this, the y coordinate. Y coordinate is the inferior deflection of the cone. As I said, most of the ectasias are inferior and temporal. If the y coordinate is more than 1 millimeter from the center, it is considered abnormal. Just an overview, this is a typical keratoconus map with a steepening within the keratometry map, elevation corresponding areas, and the thinning. And in this map, if you cursorily see, it will look like a crab claw or a butterfly effect, but if you see, there is no inferior elevation. The steepened area or thinned area is in the center. This is a PMD-like picture in KC. And this is the typical against the rule astigmatism with the inferior thinning and elevation in case of a PMD. And finally, this is one more thing you have to see. In case of the pachymetry map, you will see a pattern with inferior steepening, inferior thinning in the pachymetry map, which will look like a bell. If the map has that pattern, it's more likely to be a PMD. And this is one extreme case of superior PMD, where you can see the loop cylinder and also the inverted bell. The patient had extreme powers so that we could even visualize the angle structures without even a gonio. So this is last case where this is a child with both eyes very thin cornea, one eye developed eye drops. These are the keratoglobus and the brittle cornea patients. Thank you.
So nicely covered. It's a very volatile topic. You have covered it very well. Anybody in the audience, any questions to the speaker? Can you just sum up those findings, like which it is present, like you can say that it is keratoconus?
So, one thing which I completely skipped is, if with the pentacam, I can even use the Bellin-Ambrosio display also, which will give me a very clear idea regarding whether it is significant, the change is there. But mostly for progression and all, you can see the keratometric powers, the the pachymetry, whether thinning is happening. Sometimes we will get a very thin cornea, but the keratometry may not change. So we have to also understand whether it's an astigmatism which is progressing along with the thinning. Then only you need to treat the patient. It may diagnose, you may end up with a form crest, and there are topographers which will give you aberrations, which will give you a better idea, because sometimes aberrations happen first, then topography happens, then only refractive error changes happen. So patients saying symptoms, maybe the aberrations are happening and their vision is dropping. But if you cursorily test with other devices, that will be missed. So it's slightly person to person, and if I have a pentacam, I would go with the Ambrosio display as well.
Thank you, Arjun. I would like to continue with your next topic. Is cross-linking in ectasia. When and how?
Due to the change in the one of our speakers is unable to come, so I'm taking over this topic in behalf of Dr. Rajesh Sinha sir.
Yeah.
So I'm just going to give you just an overview of corneal cross-linking. So from its inception from the early 2000s by Wollensak and Theoseeler, this has been the gold standard method for stabilizing the cornea and preventing the progression. And Western protocol is the standard against which all other protocols has been evaluated. So again, the question is whom to treat. So you have to see the pachymetry, you have to see whether there is a progression, and your topographer will help you in identify the progression as well with serial topography. And you have to also see whether there is a refractive error correction which is acceptable for the patient with glasses or with spectacles. Over the years, the criteria have changed. The progression criteria are very different. You can get an increase in keratometry, a deterioration in visual acuity, or a change in glass powers. But even now, certain studies have included perceived risk. That is, even without documenting a progression, if you feel there's a perceived risk, you can consider to do a C3R. Perceived risk may be one of the other eye, how the other eye has behaved, or what was the age of the patient. If there is a VKC patient you are dealing with who's having eye rubbing and progression, you can consider C3R with even before you document a progression. So as in this case, one eye is gone into full eye drops and scarring, the other eye is progressing, it's better to stabilize the other eye without waiting for any progression. In this case, one eye is slowly showing to show the keratometric changes, the other eye is relatively normal, but they are thin corneas. You can do the C3R in one eye and look for progression in the other eye as long as the vision is maintained. So the overall, what is being done, the Dresden protocol, you know that you put riboflavin drops over the eye, saturate the cornea, after which you expose it to 370 nanometer of ultraviolet air light, and once it is done, almost 5.4 joules of energy is transferred, and you give the BCL if it's an epi-off protocol, as in Dresden is an epi-off protocol, and give the post-op medications. So little bit about the photochemistry. There are two types of reaction, the type 1 and type 2. Whenever there is oxygen, the type 2 reaction occurs, which has a better effect, which has more controlled CXL. When the oxygen depletes, when it becomes hypoxic, it starts producing hydrogen peroxide, which is more toxic, and the effect is not stable. So whatever protocol you are going to change, these three things, this trinity will decide what is going to happen. That is fluence, how much riboflavin is diffusing, and how much oxygen you have. So whatever modification you can do in C3R is always influenced by these three things. So over the years, conventional protocol has been proven to be very effective, even in pediatric population, especially I'm saying pediatric because over 8 years they can have a collagen remodeling and the effect may go, but even then, even our personal studies, we have seen that it has remained stable. So what are the modifications you can do? The accelerated protocols, the epi-on, epi-off, ionotophoresis, pulse CXLs, and the plus procedures. So the conventional protocol, the biggest problem is the duration. It's a long procedure, so it's a risk of infection. There may be uneven saturation. In uncooperative and difficult patients, hard to do it. So here comes the accelerated protocol based on the Bunsen-Rusko reciprocity rule, where the effect may be constant if the energy delivered is constant. In other words, by increasing the power, you can decrease the duration. But this is an inorganic theory applied on an organic body, which may not be applicable. If you see, the HEFIC group has done the study ex vivo, where comparing to the Dresden protocol, all other higher fluences have less stiffening effect. But over the years, accelerated protocol has been done and it has shown to be effective, but especially most of the 9 milliwatt 10-minute protocol seem to be the most effective among the protocols. This is one of the meta-analysis which I could see, and in the meta-analysis, except for BCVA and demarcation line, all other parameters have remained same between the conventional and the accelerated protocol. Even the BCVA, though it is better in conventional, the result is not significantly different. So moving on to thinner corneas, we have many options, but the most common option we use is the hyperosmolar cross-linking. Other options are the contact lens based or the smile lenticle based, and ionotophoresis and transepithelial. So hyperosmolar has also been tested over years and has stood the test of time. Only problem is, whatever method we are trying to swell up the cornea, increase the stroma so that we can prevent an endothelial damage, but such swelling will cause an inadequate diffusion of oxygen, inadequate diffusion of drug, and the effect may not be as good as the standard protocols. These two methods, contact lens assisted and lenticle assisted method, have been tried. Most of these cases, you have to realize is you keep a contact lens over or a lenticle over. After the procedure, you remove that. So some of the cross-linking effect is not completely transferred, and although the oxygen diffusion as well as the drug diffusion may not be as even, and many studies have shown it's less efficacious than the standard protocols. moving on to the epi on cross crawl. The problem with epi off is that you have to remove the epithelium, which is a risk for infection, is a pain for the patient. It's an inconvenience to come back for the BCL removal. So that is one advantage going on epi on. But any time you try to change the standard protocol, all these three factors gets influenced again. With the epithelium on, there is a significant reduction in riboflavin entry into the eye because it's a hydrophilic negative molecule. It does not just diffuse like that, but there is a reduction in oxygen because the epithelium consumes the oxygen, and the intact epithelium will also affect the fluence which is delivered. There we have introduced the method they have introduced the permeation enhancers, which are either alcohol, benzylconium, tramadol, or EDTA. Even the meta-analysis have shown over the years the epi-on is not as effective as the epi-off method. To circumvent this, ionotophoresis is one option they have done. Again, the negatively charged riboflavin can be introduced into the cornea by using an electric current. So we can drive the drug into the eye and saturate it and then do a C3R. In most of these cases, they have done an epi-on with a conventional protocol. But the problem is driving the drug inside does not mean that the drug will remain there, because the epi-off cases, there is a passive diffusion of the drug, which does not happen when it is epi-on. So the effect is again a little less compared to that of the normal conventional protocol. And in epi-on, again, the fluence decreases by 30% and the oxygen consumption is by about 40%. To improve it, they have taken one more minute. Improve it, you can increase the fluence or make it pulsed. In pulsed, it's not a continuous delivery. The break time, the oxygen will replenish and you can continue with the C3R, or you can supplement oxygen from outside. So last two protocols, the sub 400 protocol popularized by Hafizi is for the extremely thin corneas where the protocol remains at Dresden. Only thing which is changed is after the saturation is over, the pachymetry is measured, and based on the nomogram, the time duration to which the radiation is given is adjusted individually as per the eye. And lastly, this is putting the refractive surgery part into the C3R, which the attempt is not to remove the power, but to regularize the power, improve the BCVA. The most popular protocols are the Athens and the Cretans protocol. Athens, where they use topo-guided PRK, and in Cretan, they use the PTK along with the conventional C3R. And when not to do, always remember, and if there is any herpetic disease which can be reactivated by ultraviolet, or in case of the steroid use, or any eye which poor epithelial healing, neurotrophic, severe dry eye, you have to you have to be careful in taking up such patients, and even VKC patients, you have to control the VKC before you take up for C3R. Thank you.
Yeah, Arjun, I think you've beautifully covered the cross-linking. So just to summarize it, I think even today the Dresden protocol is the gold standard, but the only issue is the practical issue of keeping the patient 1 hour in the OT. So what we have tried to do is the first half an hour, instead of putting in the OT, you can do the scraping over the slit lamp. Okay. And in the ward itself, you can instill the drops. So half an hour, at least the patient, you're not keeping the speculum, and your bed is also not blocked in the OT. But the next 30 minutes, definitely you do it in the OT. So in all the severe cases, we don't compromise. We still go with the Dresden protocol. But the borderline cases where you just want to be sure, I think those cases, a 10-minute one is a viable option that we can accelerated one. So I think that is one important. And whenever you're doing contact lens assisted, one more practical point is, most of the contact lens assisted by default have a UV filter. So you should make sure that the contact lens you are using for this particular thing should not have a UV filter.
Thank you.
Nicely covered, Arjun. Any questions from the audience? Yeah, please.
Sir, in the last procedures, what is the duration of the pre-soaking, like with riboflavin? 10 minutes only, or 10 minutes?
Which one? Riboflavin soaking, the easiest objective endpoint is take them back to the slit lamp and see if you see an yellow flare in the AC, that's good enough for you to go and start the procedure.
Thank you.
next speaker is Dr. Madhu Diraju sir. He needs no special introduction. He is a stalwart in this field of cornea, and he is a pioneer in India who has done among the first cases of minimally invasive approach, including the Bowman's layer transplant. Over to you, sir.
Thank you. Thank you so much, Arjun, for making me part of this program. And I also thank Srini sir for giving me this opportunity to part of this Golden Jubilee celebrations of KSOS. So I think in the next few minutes, I'll try to cover the minimally invasive approach in advanced ectasias, that is keratoconus. So the scope of this topic would be under the following headings. So if you see the trends that are 1 decade trends in the US eye banks, slowly if you see the ectasia, this is the red line, that slowly the things, ectasias requiring transplants are slowly coming down. What is the reason for this? Even if you see here, the number of people who are undergoing anterior lamellar keratoplasty are way less when compared to the people requiring regular PKs, EKs and other grafting. So the reason for this is thanks to the technology that now we have access to, as already Arjun has beautifully covered, the recent topographers that we are having access to with the Steinflug imaging or the ASOCT epithelial layers, and also all these things you can early diagnose the disease quite early. And also cross-linking has definitely changed the way in which we manage keratoconus. So once you have an early identification followed by an early intervention, most of these cases do not progress to a condition that would require a surgical intervention. So if at all there are cases that we have missed and thus have gone into advanced keratoconus, do we have an option of not going into a transplant? Can we evade a transplant somehow? Was the idea which we had tried some procedures. So even scleral lenses previously were quite expensive. They were imported, so they were costing around 1.5 to 2 lakhs to the patient. But now I think after the manufacturing that has started in India by LVP and other companies, the cost of the lenses have considerably come down. And especially now you have the Mini Cooper lenses, that's the 1-fit scleral lenses. They have quite a bit of flexibility. Like you can, most of the advanced cones also, you can definitely have a good cover and they can have a good best corrected visual acuity. Just nothing else, just scleral lenses. If they're having good vision, leave the patient. That's the least invasive thing you can do. And these lenses also, fitting can be seen with slit lamp. And also you can see, as I've shown them, software is available in Sirius and Sirius Plus for this contact lens fitting. That also you can use. These lenses are relatively affordable and they usually last from 3 to 5 years, and a 6-monthly service is done by an optometrist. But you have to have a well-trained optom, and patient education is paramount importance. For the initial trial, you have to spend at least 4 to 5 hours, make the patient wear them, and make them stay back in the hospital at least for 4 to 5 hours. Make sure that the fit is good, the patient is comfortable, and knows how to put the lens on and off. So if you are able to do this perfectly, 80% of the cases you can avoid a transplant altogether. Next are tissue sparing techniques or the less invasive techniques I'm going to tell you. So the black thing is the tissue that we are going. This is previously, all of you know about Intacs. Intacs became less and less popular because of the PMMA material that was used, and there were a lot of extrusions and infections that were associated with it. So thanks to Dr. Susan Jacob from Agarwal's, she developed a corneal allogenic intrastromal rings, that is the KSOS procedure. And we have tried something called as the Bowman's layer transplant that I'll show you in the coming slides. So this is the KSOS procedure that you can observe in the video. So here, like you have your regular trephine, this trephine has a double blade. So it cuts in 2 places. So when you cut a tissue, you get a ring, okay? So that is the ring you are looking at. That ring you separate it into 2 hemispheres, then you spread it out. This is the donor part. So this double trephine is available with Madhu instruments. And in the recipient part, the pockets can be made with a femtosecond laser if you have an access to. Or there is one more instrument from US that you can also manually try to create these pockets. But femto has a better accuracy in doing it. So that is how you insert and you excise the excess tissue out of these pockets. Similar thing you do in the other semicircle. So in this condition, as you are leaving the central part clear, the visual acuity and the correction of cylinders is better, and you can titrate it according to the cone position. So this is the procedure of CARES, and this is how it looks post-operatively. So next is the Bowman's layer transplant. So Bowman's layer transplant, so these are the cases that are not suitable for cross-linking, that they have too low pachymetry. In these cases, you don't want to do a DAL. In these cases, you can try this procedure. So this is the donor preparation. So you mount the donor tissue onto the Barron's chamber and you scrape off the epithelium and you stain the Bowman's layer with the blue. Bowman's layer is usually limited to the central 7.5 to 8 millimeters of the cornea. Like you do your can opener technique, you just give nicks in that area so that you have a plane from which you can start peeling out the Bowman's layer. Ours is not a Bowman's layer standalone technique. We also harvest 100 microns of stroma along with it because we want to add volume into the cornea and make it suitable for cross-linking if required at a later stage. So this is how you create the tunnel with your regular tunnel blade. And just by lifting and putting the tangential pressure, you get a correct plane and the interface will be smoother when you do it in such a way. You can just peel it off once 3/4 of it is complete. So that's the Bowman's layer along with stroma. Now you can refine it to the size you want. Usually we do it from 7 to 8, in between 7, 7.5 to 8, depending upon the location of the cone. And once that refination is done, your donor preparation is there. And you can smoothen out the stromal surface either with a diamond burr or a 15 number blade and make the surface smooth so that you don't have any interface issues. Now coming to the recipient preparation, you mark the central marking of 8 mm so that you can put the donor into that area. First with the with the regular crescent blade you can go. These are the Summerbusa lamellar dissectors that we use in DSEC. Same thing you can use in the donor recipient eye, and you can try to create a mid-stromal pocket. You have to be careful in the central part where the thinning will be more. So you have to be gentle in your procedures when you are doing this. So once you create this mid-stromal pocket centrally in the 7.5, 8 millimeter, make sure you hydrate the stroma well and make sure there is no blood or any debris. And once that is done, you introduce a glide and then introduce the Bowman's layer stromal transplant into it. You also can create the stromal pockets using a femtosecond laser if you have an access to it. So once that is done, you can center the graft well and iron out any faults. And that's the end of the surgery, and that is how it looks post-transplant. So I think the main idea of Bowman's layer transplantation is by adding tissue, first you are making this cornea less steeper, you are adding volume. So these patients who are previously intolerant to contact lenses would become tolerant to contact lenses. Most of their higher order aberrations would also come down because you're making the cornea more regular. And so far we have been doing this technique from 2017, and none of the cases so far required a transplantation. Most of them we are managing well with regular contact lens or scleral contact lens. We tried combining with cross-linking in few cases, but the requirement of cross-linking is also very less. That's about it. Any questions in this I can take. Thank you. Right.
So, thank you, sir. That is an excellent talk. Now we move on to the final topic, that is keratoplasty, the final frontier in ectasias. I wanted to ask you, sir, what about the post-op steroids you have to give for a long time?
Post-op, you can give regular steroids, antibiotic and steroids for 1 month, and then I usually taper it to lotipred and continue for 8 more weeks. Antibiotic and steroid like prednisolone or dexamethasone for 1 month. Initially, you can also keep the hypersol so that the hydration is better for 1 week or 10 days. You can use the hypersol so that entire water is swollen out and you get a better result.
Do you suture the wound? No, you just leave it.
No, sir, it's just like an
pocket,
SACS
yeah.
wound. We can place a BCL
Okay.
and leave it. So wound suturing is not required. In cases like where we do in VKC and all,
Okay.
there the tunneling becomes difficult. So once we have any free flaps or something like that or cut edges, we put a suture. Otherwise, routinely suture is not required.
Thank you. Good afternoon. Thank you, Arjun, Dr. Srini, for the opportunity. So my topic is on the surgical management of keratoconus. So mainly I'm talking on DALK, deep anterior lamellar keratoplasty. We all know there has been a significant change or a paradigm shift in the management of surgical management of keratoconus. So these are some of the accepted indications for DALK in keratoplasty in keratoconus, like advanced keratoconus with poor vision with contact lens or contact lens intolerance, non-resolving eye drops or healed eye drops with poor visual acuity, and the percentage of patients undergoing keratoplasty in case of keratoconus is around 12%. And younger age with the steeper keratometry are more prone to progress fast, and these are the cases which require DALK. And patients with corneal scarring in keratoconus, this scarring could be due to the advanced nature of keratoconus itself, or it could be due to scarring because of C3R. You can have a central thick haze which can affect the vision, or scarring due to progressive melting of cornea following C3R, and infection or infective keratitis in the center causing scar can be the indication for DALK. And there are various techniques which has been described, and the most common and the easiest way of reaching the desmids is a big bubble technique described by Anwar and Teekman. And this is followed by the other common technique is layer by layer dissection technique, and there are many other techniques which are described by different authors, multiple bubble technique, or injection of saline into the stroma to separate the stromal layers, or dissection using viscoelastic substances, or you can use microkeratome or femtolaser to separate the stromal layers and then reach the desmids. So, a thorough preoperative evaluation of these patients is very important. It can be a slit lamp examination or anterior segment OCT examination. There is a classification based on the anterior segment OCT classification. This actually classifies keratoconus into 5 stages. The stage 1 is the earliest stage where you see a thinning of the epithelium and stromal layers. No scarring, nothing, but stage 5 is panstromal scarring. That is an advanced case of keratoconus with the healed eye drops leading to panstromal scar. So this classification is important to plan your surgical technique or a surgical procedure. And this is the algorithm for performing DALK, taking advantage of the preoperative OCT up to stage 3A, 1, 2, 3A, you can safely go ahead and do a DALK, big bubble DALK. And beyond that, 3B onwards, that is 3B is actually there is a stromal thinning, but there is a scarring of the posterior stroma. This is the stage 3B. And 3B onwards, you should go ahead and do a layer by layer manual dissection to reduce the complication of perforation. And there are three types of bubbles. Like type 1 bubble is the white margin bubble. This is actually the strongest bubble. The chances of perforation with the type 1 bubble is very less as compared to type 2 or type 3 bubble. Type 2 bubble is a thin margin bubble or a clear margin bubble, which is a large bubble as compared to the type 1 bubble, and it is more prone to perforation. And type 3 is a mix of type 1 and type 2 bubble. You can have a large type 1 and a small type 2, or a large type 2 and a small type 1 bubble. I just want to show few cases. This is a video demonstration of type 1 bubble formation. It's a nice, it's a clear-cut margin it has. It's a white margin bubble, and the floor of the bubble is thick. Actually, you have desmids and duas layer as the floor, so that constitutes around 30 microns. Whereas type 2 bubble, it is only the duas, it's only the desmids layer. This is again a case of type 1 bubble. Just showing a slow motion video of the big bubble formation. I have injected a small air bubble to demonstrate. You can see the bubble, big bubble forming, and it's displacing the small bubble in the anterior chamber to the periphery. So this is a type 1 big bubble. So a few case examples. This is a young boy, 12 years old, with a visual acuity is only 6/60, is not improving with glasses, and this is the topographic picture. 271 is the thickness and high astigmatism. Patient is not improving beyond 660 with the best of correction. And I usually do a big bubble dark if there is no scar. You have seen the big bubble here. I do a superficial lamellar keratectomy and then de-roof the bubble. This is using a 11 number blade. This is a nick incision I have made, and I am injecting visco into the nick incision to keep the desmids away from all the manipulations. And with the help of a 1/2 scissor, I go ahead and excise the posterior lamellae up to the trephination margin. Once this is done, I prepare my donor tissue with the Vexel sponge. You just scrape off the or peel off the desmids and place the donor tissue on the host bed and suture it. I usually use 16 sutures if the graft size is more than 8 millimeters, and less than that 12 sutures I put. This is not a rule. I usually follow this. Coming to type 2 big bubble, it's a large bubble. You can see the large bubble. It is a clear margin bubble. The previous one had a white margin. This is a clear margin bubble, and tends to rupture in most of the cases. Carefully you can dissect it, but most often you end up with a perforation. A case, the patient has counting finger 3 meters with the central corneal scarring, and this is the topography. And this is anti-segment OCT. You can see the highly curved cornea. It's around 70 diopters, and you have a scarring extending up to deeper layers of stroma. And these are the cases you can expect type 2 or type 3 bubble. I'm just injecting air bubble into the stroma. So in the third attempt, I could get a large big bubble. That is a type 2 bubble. So identifying this bubble is very important. So I started doing a manual layer by layer dissection. So you can go layer by layer. There are multiple small bubbles in the stroma, so that will give us a guidance. Actually, you can use it as a guide and go just short of these small bubbles. You can stay away from these bubbles. and then place the donor tissue on the host bed. This is another case of healed eye drops. So you can see the anti-segment OCT picture, the scarring around the DM rupture tear, and this is the topographic picture. 70 diopters is the is the keratometry, and this is the case. Like since the DM tear is not in the center, I attempted a fake DALK. So here I am injecting air into the stoma, not to create a big bubble. It is just to create an emphysema of the cornea, and that helps me in dissection. And all these multiple bubbles, they act as a guide. We can stop dissection just short of these multiple bubbles. So once dissection is complete, you place the donor graft and suture it. This is the first day post-operative picture of the same patient. You can see a scar here. There's a tear in the desmoids. This is 6 weeks, and this is 1 year post-operative picture of the same patient. Since this scar or the tear is not in the center, the patient had a very good vision, visual acuity of best corrected visual acuity of 6 parts. This is the last video. It's an advanced case of keratoconus, the healed eye drops, and again there is a tear in the center. So I've injected air, and this air acts like a tamponade. The one advantage here is, even though the scar, the tear is such a large tear, not in the center, slightly away from the center, but usually it won't enlarge. That is because of the margins gets fibrosed over a period of time, so it won't enlarge. So in spite of having such a big tear, you can continue with the DALK. This is the post-operative picture. This is a 6 months post-operative picture, and this is 2 years post-operative picture. You can see the tear here, which is sealed very well. So we have published the outcome of deep anterior-lamellar keratoplasty with the intraoperative perforations, and the most of the perforations are due to the pre-existent DM perforation, healed eye drops, and the results were good. And another indication is, as I have mentioned, this is actually post CXL infective keratitis, which has healed well with a scar, dense scar right in the center. And the BCV is poor. In such cases, you can go ahead and do a DALK. This is a case of progressive melt. Particular patient developed progressive melt. This is the thinning which is happening, and ended up with a desmetocele. And we went ahead with the keratoplasty. I tried a DALK in this case, but I could not preserve these desmoids very thin, and ended up with the PK. So there has been significant changes that has happened in the last couple of years in the management of keratoconus, and surgical management also has changed. Madhu has his own technique of Bowman's transplantation, many other techniques, and DALK in healed eye drops itself is a new evolving technique. So you can always do a DALK in healed eye drops if the scar is away from the visual axis. And DALK is very safe and effective in the management of indicated cases of keratoconus. Thank you very much.
Thank you, sir, for those wonderful videos. I think they're very complex surgeries, but you made them look very simple. Thank you. Any questions from the audience? I think we have 4 minutes before we hand over it to the next session.
Thank you.
Right. Thank you, sir.
Once again, on behalf of KSOS, I want to thank both the speakers. Both the speakers have dealt very, and their topics to the best of their abilities, and especially sir, those were very complex cases, and you also sir were very pioneering to do a lamellar dissection in a thin cornea. It may look very simple, but once you start doing it, you realize the complexity involved, and the thinner and the scarred cornea, attempting a big bubble itself is a challenge. This may look very simple, but it's like how you say in Guinness Records, these are professionals, don't try it at yourself. So I thank both the speakers, and I hand over the session